for example, like contraindications, cardiovascular disease, unstable or severe hypertension, compromised vascular circulation like peripheral vascular disease, hypercoagulable states like blood clotting disorders, varicose veins in the indicated limb for BFR intervention, atherosclerotic vessels causing poor blood circulation, and IV drug use in the indicated limb for BFR intervention. And then it talks about, I won't read all of this to you guys, but like and then the next thing is musculoskeletal injury, for example, like a recent muscle trauma or crush injury, right? Like, so we just want to be cognizant that the patient is stable and safe, right? And then other factors is listed uncontrolled diabetes or sickle cell disease or trait. So that's also more like in the precautions section versus like it's contraindicated. And then it goes on to list like the precautions, and there's also some risk factors that I'll go over as well. But for the most part, this is a nice little reference, and it should just stay with the machine at all times. It also goes over like how to use the device, but we'll talk about that today. So these are the three, I guess we'll just start with the machine a little bit. So these are the three different cuff sizes. For the most part, you're going to be using the red one for upper extremity unless the patient is a really big person and has a lot of muscle mass or that type of thing. You might have to go to blue, but for the most part, red is going to be upper, blue and green are going to be lower. And we'll go over how to place those. And these are the three, obviously it's color coded, but these are the three sleeves that go with the corresponding cuffs. Okay, so I think like just starting off, I'll just talk briefly. I think you guys kind of have an idea of what BFR is, but essentially for documentation purposes, this is the first thing he talked about, is you certainly want to make sure that you're documenting in your note the patient's personalized pressure, which is calculated by the machine, and then the total tourniquet time. So how long was the patient actually on the tourniquet versus like when they're in a rest phase or they're between exercises and it's deflated. So you could be super specific and say, okay, well, the tourniquet time was for 6 minutes for this exercise, and then you deflated, and then it was another 6 minutes for the second exercise, right? So that's probably how I'm going to document it, just so I can keep track of like what the patient's doing and which exercises they're doing. Okay. In terms of charging, the way that, so there's a couple of different things. So there obviously isn't a code to charge for BFR yet, but you can certainly pair that just like we would with another modality. Like I'm thinking of like neuromuscular e-stim, where we could charge it under that, or you could charge it under Therax if they're doing an exercise while they're on the stim. So that's usually how you can charge it as Therax. Therapeutic activity, if they're doing like a squat or a lunge with the device on. Okay. If they're doing it passively, that's really the only time you can't really charge it. Like say they're literally just lying there, they're post-op day, 3, let's say, and they are in so much pain, they've got a lot of swelling, and you're just doing it to get like that physiological response, then you may, like they could be doing like ankle pumps or like quad sets, and you can get away with it there. Or if they're literally just lying there and doing nothing, then you can't technically really charge for that. So you could certainly have the patient do something else, I don't know, upper, say they're doing like the arm ergometer and you're charging for that, but then you might have to put them on the BFR, like have them come in 10 minutes early or something where you can, watch them while you're maybe with your next patient. Do you know what I mean? Because if you're just doing it passively, you can get away with it, but you can't really charge for that right now. So does that make sense? Okay. And then it says when to use BFR. So we can use it very early in the rehab to limit atrophy and restore and maintain muscle quality, to hit multiple targets in older clients on days where pain might limit exercise, to reduce pain prior to loading heavy, as a light day in a rehab block, as a finisher to ensure sufficient volume, or as a means of maintaining general fitness. The principles are basically you're blocking the venous return, but allowing partial arterial flow. You always want to apply the tourniquet as proximal to the limb as possible. So for lower, it's always going to be on the proximal thigh. For upper, it's going to be on the proximal upper arm. The limb occlusion pressure, LOP, is generally the more accepted term But it's synonymous with like arterial occlusion pressure. So if you hear LOP or AOP, they're synonymous terms. For muscle strength and hypertrophy, so we're going to talk about like what are you trying to achieve with using the BFR. For muscle strength and hypertrophy, for lower extremities, the limb occlusion pressure is going to be between 60 and 80%. And for upper, it's a little bit lighter at 50%. And you want to really use light loads at about 20 to 30% of their 1 rep max. So we'll talk about how to calculate that, or at least estimate it as a starting point, but certainly you may have to, see how the patient's doing with a particular exercise and go down or go up, and we'll talk about that in a moment. To improve vascularity of a joint, the limb occlusion pressure is typically higher at about 80%, and that's like if you're using it for pain modulation on that patient who's like post-op day 3 and they're really struggling with a lot of pain and they're just not tolerating any exercise. Like that's when you do more of like the passive BFR and you're just trying to help modulate their pain, get some blood flow and that type of thing. Machine exercises are typically best. So it's a great way to do it more objectively too, and track how much load you're using. And you're going to perform the Doppler every session. And the Doppler is this, it's called PTP, so I believe that stands for personal tourniquet pressure. So it's really like, that's when I was saying, you're going to have the patient lie down. They're not going to talk, they're just going to completely relax and not move. And you hit like the PTP button, that's like doing your Doppler. And then that's when you're calculating their personal tourniquet pressure. Or their limb occlusion pressure. And that you would record that in your documentation. That's really important to document that number.
Did you mention if that was done in the position of the exercise?
No. So regardless of what exercise they're going to do, they have to lie down and just completely relax. They shouldn't be talking. They shouldn't be doing anything. And that's when you would hit the blue button. That's the first thing you're going to do is calculate the Doppler. Once that is calculated and there's no error codes, sometimes that can happen if like the cuff isn't on properly or the patient was moving. And we'll talk about like strategies to get around that. But yeah, no, you do that. Once it's calculated, then they can get up, move to a machine, move to just a seated position, standing, whatever you want them to do for the exercise after that. Okay, so we'll just talk about the protocol. So typically the BFR protocol is 30, 15, 15, 15, meaning the first set is 30 reps and then subsequent sets are 15 repetitions. The goal is really to go through those 4 sets, and the 4th set is either 15 reps or 2 fatigue. So if they hit fatigue at the 10th rep, at the 5th rep, they're done that set. And that's kind of what you want to do. Like you don't necessarily want them using, say, like a 3-pound weight for a bicep curl and getting through those 75 reps and knowing they could do more. You want them like almost like struggling to get through that 4th set where they're like, oh, they barely make it to 10, or they fatigue before, or to 15, or they fatigue before the 15 reps. Then you know you've got the right number. Does that make sense? Okay. So the ratio is typically 1-to-1. So you want that 2-second concentric phase, 2-second eccentric phase. So you don't have to worry about one longer than the other. Always have 30 seconds of rest between sets, and the machine will tell you, because it'll tell you the work, and then it'll say rest, and then you hit the rest button, which kind of gets a little annoying because you actually have to like physically hit the rest button each time. So you really have to like pay attention to what the machine's doing, what the patient's doing, which is not a bad thing. You should be paying attention to that anyways. During the rest, that 30 seconds of rest though, the cuff stays inflated the whole time. It's not until they're completely done those 4 sets that you want to deflate the cuff. And so 30 seconds of rest between sets and at least 1 minute of rest or longer between exercises, which is pretty typical. Like you're gonna have to deflate the cuff anyways between exercises, and then kind of, that's plenty of time. They'll be on 1 minute of rest or longer when you're doing that. Do not deflate the cuff between sets of the same exercise. I already said that. Do deflate cuff between different exercises, or if you're working different muscle groups. Set 1 is always going to feel easier because the muscle still has oxygen in it. And then set 2 and beyond will feel much harder as the muscle becomes deoxygenated, and this will activate the fast twitch fibers, which is the goal. We want them to fatigue to failure, and that's that, like, they're gonna be feeling that muscle burn, and they're gonna be like just struggling. By that 15th rep each set, they're gonna be like, I don't want to do it anymore. Like, literally, it was so funny. We would be like, I was holding like a 2-pound weight, and I was like, I don't even know if I can make it to 15 on my 3rd set. It's pretty crazy, yeah. Typical treatment time for one exercise is about 6 minutes. I think this is preset for like 6 to 8 minutes for each exercise, so it makes it really user friendly. And typically the maximum, the number of exercises you're going to do in a typical section shouldn't exceed 5. And with our 30-minute treatment sessions, I don't think we would be able to even do more than that. So that's fine. Not have to worry about that. Yeah.
Can I just ask a question?
Absolutely.
So if by set 4,
yeah,
they're 15 reps they can do easily, would you just add more weight or
correct?
resistance? Is that how you?
100%.
Okay,
So you would note that so that the next time they come in, you're going to start with a heavier weight next time. Exactly. Because if you were like, they get through the 75 and they could have done more, it was too light. Yep. Okay. So next session they come in 2 days from now or next week. You want to start with a slightly heavier load. It could even just be 1 pound or 2 pounds depending on the patient's feedback.
Okay, perfect.
Yep. So in terms of calculating the 20 to 30% 1 rep max, he actually talked about, I thought this was kind of nice because it's an easy way to just get a quick estimate, is using the RPE scale. So it correlates with the same percentage. So if they're saying they're rating themselves at like a 2 or 3 on the RPE scale, that's about 20 to 30% of a 1 rep max. So you can kind of start there and then, go up or down depending on how the patient looks doing the exercise.
And that's using the 0 to 10 versus like
correct.
the 6 to
Correct. It's a
19.
0 to 10 RPE scale. Yeah, that's a good clarification. There is another way. I mean, I don't necessarily need to read this off to you guys. You can look at this, but if you are calculating it and you want to get a rough, like a more accurate number, you can just kind of read through my example here in terms of how to calculate that. It would have to be, you'd have to have them do like an exercise, for example, I'll just read it, 50 pounds for 10 reps of failure. Like, let's say they were doing, I don't know, a leg extension, and they did 10 reps, and at 50 pounds, like, that was it, right? That was their 10 rep max. Then you would calculate, you would times that number by 2.5, so 10 reps times 2.5 is 25, and then you would take, let's see, yeah, I don't even think I want to just, do you guys understand that though? Like 50 pounds, 10 reps is to failure, 10 reps times 2.5 is 25, then you take 100 minus 25 is 75, that's the percentage, 75 is the percentage of the 50 pounds that represents your theoretical 1 rep max. Right. Then 75 divided by 100 is 0.75. Estimated 1 RM at 50 pounds, you would divide that by 0.75 is 67 pounds. And then if you want the 20%, 1 rep max from that, you would have to times it by 0.2, or if you want 30%, times it by 0.3. Okay? And that's, Kendall, this, if patient hits 75 reps for a specific exercise, then you need to increase the load next section. That was your question. Yep. I'm gonna skip through like the history and the literature, if that's okay with you guys. You can certainly ask me questions if you have any questions about those notes. If you go to like the methods section, so here it talks about the best practice. Pressure setting should be based on the limb occlusion pressure. Research studies have shown that occlusion can be achieved using a lower pressure when using a limb occlusion pressure method in conjunction with a wide tourniquet cuff in adult patients. So obviously the limb occlusion pressure is individualized, but that's why the cuffs are super wide, because you kind of want, you want that. What affects the pressure? There's a lot of different things. So the cuff width, systolic blood pressure or limb circumference of the particular patient, body position, female or male, limb density, and laterality. The cuff width and the limb circumference are the biggest factors. So basics, let's see, setting up your patient. Yeah, so, and we'll go over this when we get to the lab session, so selecting the proper cuff. I was just telling them before you got here, red is gonna be upper, unless you have like someone with a really big, then you might go to blue, and then blue and green are gonna be more for lower extremity. Ensure the Velcro has contact. I'll show you guys how to do that. 2-finger test, right? You should be able to get, you shouldn't really be able to get one finger underneath the cuff, between the cuff and the limb. And then what you can do too is, let's see, yeah, and then that's when once you get the cuff, you hit the blue PTP button, and then it's either gonna accept or reject. So accept means you've got an accurate number, you can start exercising right away. Reject usually means like there's an error with the reading, and it could be that the patient was talking, or the patient was moving even a little bit, and so some of the things that you can do to troubleshoot: check the cuff size and snugness, check subject positioning and making sure they're completely relaxed. You want them supine and relaxed. Have the subject sit up to kind of increase their blood pressure temporarily, and then have them lie back down and then retest. Or you could even have them perform some isometrics, like some quad sets, and then retest, because sometimes the patient is kind of cold, they're coming in, you almost want to do a little bit of, they could even do like a warm-up, they could do a 10-minute warm-up on the bike, and then come over, have them lie down, and then hit the button. Does that make sense?
You actually show it, we just want to see.
Oh,
Nothing
the
else.
machine?
Yeah, so
Yeah.
when you're not, like, when you're...
When we get to the lab
Yeah,
section?
exactly.
Okay, cool.
Okay.
Yeah, of course. So cute, they're like waiting over there. Okay, so there are 3 different types that we're gonna be using the BFR for. So the first one is passive, and that's really talking about like early stage, those post-op patients who are coming in within the first week of their surgery. They're in, maybe more for pain modulation, they can't really do much, they're not comfortable, and you're just gonna put them on the machine, they're gonna lie there and do nothing. So that's passive. They're really not doing any type of exercise with it, or they could be doing some like quad sets or ankle pumps and things like that that are really tolerable for them. Number 2 is aerobic. So this introduces some voluntary muscle contraction, and in rehab is typically used as a means of progression to resistance exercise, or a means of adding exercise volume. And then number 3, which is probably what we're going to be using it the most for, is resistance, to build muscle strength and hypertrophy. It's the most powerful rehab tool. It gives us the ability to increase muscle size and strength when we otherwise could not. So you can see this little thing I made up in the middle of the page here. So it goes from passive aerobic to resistance, and it just kind of shows the breakdown of what you're trying to achieve at each of those levels. So for example, under aerobic, like using the Ultra G or the bike or the treadmill or the upper body ergometer, and having the cuff on them while they're doing just some aerobic training on the machines. Resistance, you can do single joint, multi-joint. So single joint would be your knee extension machine, versus multi-joint having them do a squat or a lunge while they have the cuff on. And then for passive, it's really just like ischemic preconditioning, and it's muscle sparing. We're not really trying to build muscle at that stage. We're trying to reduce the muscle atrophy that's occurring, after their surgery. So for passive BFR, like I said, it's early post-op or post-injury. You just let the tourniquet do the work. The pressure is going to be about 70 to even 100% limb occlusion pressure. And the parameters or the protocol for that is 3 to 5 bouts of 5 minutes on, so the cuff is on, and then to 3 to 5 minutes off. So it's the same ratio of the machine working to the rest when it's turned off. And this is probably not going to be realistic for us, but the goal is to do it 1 to 2 times per day. So it's like as many times as you can, essentially, with those post-op patients, or the patients coming in post-injury. You can place the tourniquet on the non-surgical limb, or the non-injured limb for a crossover effect, just like we would do with some of our strengthening in general. If it's too painful for the patient to have it on the surgical limb. And then I just kind of broke down, this is an example of a patient maybe doing some quad sets with the passive BFR, but you can see it's still the same protocol of like 30, 15, 15, 15 would be how many quad sets they'd be doing, or if even the quad set was too painful, they were just literally lying there and doing nothing. But that would be the breakdown of that. And then if we flip over to aerobic BFR, so the intensity with the BFR is typically less than 50% of their VO2 max or their heart rate reserve, and the pressure is a little bit lower, so you can do 40 to 80% limb occlusion pressure. Duration is just kind of continuous, like while they're on the bike or they're on the arm bike, 5 to 20 minutes. It could even be like your whole treatment for that day potentially, and you would do this for about a span of 6 to 8 weeks. They can do intervals on the bike or a steady state. Kind of depends on what they can tolerate and what you're going for. If you're doing intervals, then you would want to do 5-minute intervals, then deflate the cuff and repeat that for about 3 bouts. If you're doing steady state, just leave the cuff inflated the whole time. And then if we go down resistance training, that's a little bit more of what we talked about during the course. The load is about 20 to 40% of their 1 RM, and the pressure is about 40 to 80% limb occlusion pressure. So it's actually, it's the same as the aerobic. And then we've already talked about the parameters. Rest is 30 seconds between sets. Pace is 1 to 2 seconds concentric to eccentric, so it's the same. And frequency is 3 to 4 sessions per week. The goal is to hit the point of fatigue in the final set. We've already talked about that. If they hit the 75 reps, then you have to increase the load the next session. BFR does not appear to cause muscle damage, so you're not too worried about delayed onset muscle soreness, which is more metabolically driven. So that's important to note too. I think a lot of patients do have some idea of what DOMS is, so I think just making sure that they're aware of that it's not necessarily the BFR that's causing that, but the work that they're actually doing. Yeah, of course.
With the 20 to 40% 1 rep max, I know you gave us the RPE scale to use as well.
Yes.
Are you finding, or I don't know, like in the thing that you went to for this training, are they talking about really bringing people through a 1 rep max on the uninvolved side to help determine that, or are they using what are they using to determine that?
I mean, kind of, you could do one or the other. Like I personally will probably do the uninvolved, if that makes sense, especially if we want to train the uninvolved side as well. Or I don't know, like maybe I'm thinking of like an elderly frail patient, who, maybe let's see how you feel and then rate yourself on the scale, and then that might give you just some more information, but typically I'll probably use the uninvolved side.
And are you going to like a max? Are you doing like a 80% on the uninvolved, or are you doing the 20 to 40 and using the RPE scale? Like, how are you coming up with, what I mean? Like, are you doing a full on?
Probably like that,
80?
yeah.
Okay.
I mean, you've used it before too. What do you think?
Anecdotally, you won't have to use much resistance at all, especially in those first sets.
And honestly, during the seminar, we were just guessing. Like
That's what I thought I would do.
And honestly, you can do that.
And even the students were just asking
100%.
And I'm
like he was literally like, pick up a 2-pound weight and try that.
Right.
Go through your 30, 15, 15, 15, and then if you make it to 75, go to a 3 or 4 pound.
Okay.
And then he's like, if they're struggling,
That's
say in the
real life
second
clinic.
totally. That's probably what we're gonna.
Okay.
It's gonna be the quickest way.
Okay.
And I think the more you use it, you're gonna get a sense of what people can do with different exercises.
Okay.
And even just like I remember doing the bicep curl, I did a 2-pound weight and I struggled to get through the 4th set. Like I was like, I couldn't have done more. And I was like, that was the appropriate load for me. Versus like if that was easy, if I was getting through the 4th set and I was like, okay, like it was too light. I'd go up to like a 3 or 4 pound weight.
Even charts that are coming out, that are going to help to guide us with
I'm not sure.
Like normal, like knee extension. What would be the
maybe like age-related norms or something like that?
Like I was wondering if we could even use those to guide what we would give a patient.
I don't know if anything like that exists yet, or at least they didn't talk about that during the course.
Okay.
But
again, my experience is like you do body weight of the movement that first session, because they're probably not going to tolerate this being on for that long anyways with just body weight. And then then they know what to expect. And then the next time around, you add a pound maybe for the extension.
Yeah.
Like
Okay.
2 pounds maybe, right?
100%. And even like I was doing like lunges, like a stationary lunge, and that was enough. Like just my body weight, I was struggling like to get through the 4 sets. Like so for like more like functional strengthening, you're probably going to just do body weight unless the patient really needs some load. But if they're able to do some load, then you're almost like, why do they need BFR? Then you can start to transition them just to more strength training if they're at that point, right? Versus like a one joint exercise, like an open chain exercise, like a knee extension.
Well, I'm
or
thinking about
bicep curl.
ACL. I'm just
Yeah,
thinking
like a
about
knee extension,
ACL,
you
So
mean?
just so
Yeah.
even if you were operating within a safety arc to
Yeah.
not go to the end,
Yeah, say like 90 to
but
40.
just gravity alone on
Will be
that limb is
plenty.
probably going to be enough.
Yeah.
Totally. And that would be like your starting point, right?
Yeah.
And then if you know if they get through the 75 reps and they could have done more, then add a 1 pound ankle weight
Gotcha.
or a
That's
0.5 or whatever.
Okay.
Yeah, certainly. Okay, so I'm not going to talk about all the mechanisms. Safety. Okay. So the safety section is just kind of talking about, I think, Virchow's triad. I don't know if I'm saying that correctly. But the 3 things are endothelial damage, stasis, and hypercoagulability. So basically, Rudolf Virchow developed a triad of contributors to clot formation. So presently, it is believed that 2 of the 3 must be present to significantly increase one's risk of clots. So that we're talking about, like, is it appropriate for someone, say, like with a blood clotting disorder to do this? Generally, he said during the course that it's generally safe, to be honest. Even if they have 2 of the 3, it says down here too. There's no signs of clotting cascades in the literature for young, old, cardiac patients or post-op patients, both in the acute or chronic studies, that there has been really any adverse events in all of the studies. So generally, it is pretty safe even to do with people who might have 2 of the 3. I mean, you may want to monitor them and make sure it's safe for them to do it, maybe. And we'll talk about like this is, it didn't print off very well, but it's better in the slideshow I sent you in terms of like, can I do BFR with my patient? Do they have thrombophilia? Yes or no? And this is like kind of you just go through this, and then if you get to the bottom and it says consult medical team, but risk seems low, certainly if you should check with the doctor and say, reach out to the physician and say, hey, I know the patient has a history of X, Y, or Z. I would like to do BFR with them because of these benefits, and get their opinion. And if the doctor is like, no, I mean, hopefully more of the doctors are educated with BFR, especially if it's more like orthopedic based, but I don't know, you may have to do some education even with the physicians, and just if they don't know a lot about it, but generally it's very safe, and the literature shows that is the general consensus. Yeah, this didn't turn out very good, so I'll see if I can get a better picture of that for you guys. And then central cardiovascular responses. So yeah, this is again just like more studies just showing different responses. And I don't know, do you guys want me to go through all of this? We certainly can. We have the time, or we can just kind of skip more. A lot of it is just like the science behind it, the literature behind it. So if you guys want to just go over that at some point and let me know if you have any questions. If you flip over to the bold section though, where it says like acute rehab, like we can talk about, this is probably a little bit, this would be good to talk about, is under acute rehab it says, when should we begin passive BFR post-operatively to combat that disuse atrophy? And there are a few different studies that he talked about, but generally it's pretty safe to, like this one study by Noyes in 2021, they started at about 3 weeks post-op, but some studies are recommending as early as 2 days post-op. So honestly, if we're seeing that patient in the first week post-op and they're in a lot of pain, or they're just not moving well, like do the BFR even passively, and that can help with muscle sparing quite a bit. And then let's see. Yeah, so the general takeaway if you're doing it passively in the acute phase is let the tourniquet do the work for the first 1 to 2 weeks post-op. They don't have to do anything. If they can tolerate doing some quad sets or ankle pumps or glute sets, they can certainly do that, but just let the tourniquet do the work. And that's what this talks about down here too. It's just the parameters again.
I have a quick question.
Yes.
So, like the passive BFR,
Yeah.
the only thing I'm thinking is 2 days post-op are incisions, right? And it says
Yes.
here to wait 2 weeks, but then a lot of this is saying do it 2 days. So are they talking about contralateral limb, or are they just doing it 2
No,
days?
so
like, on
that came up
same-
during the course, was like, what about the incision? Is the incision's not healed by then? And they generally, it's not an issue.
Okay.
It's not an issue at all. I mean, especially because if it's knee, especially your ankle, like the cuff, it'd be more about like the cuff placement,
pressure,
right? If
yeah.
that's not near the incision, like maybe a little bit more careful for
Yeah.
hip, right? But even then, like if it's like a total hip, like you're probably not going to be an incision unless it's like a big incision. Then I would say be more cognizant of that. I wouldn't do it if it hasn't healed yet. Does that
It
answer
does.
your
And that's
question? Yeah.
what a coworker of mine.
That was
we were
actually a
told,
question
like,
that
don't
came
use
up
it
during the
until the
course.
incision's fully healed, which could
No.
be like 4 weeks,
Yeah.
right? But then
You can
my
start
boss
it.
was doing it like 2 days after.
Exactly. You can do it, and
So-
it's been shown to be very safe. So
Cool.
it hasn't shown any. There's been no issues with that.
And this probably goes back to the other articles that you noted, but
Yeah.
like the importance of like reducing edema and the pain response
Yes,
has,
and that's it.
which has been like, this is why they're bringing it to a lot of OA patients.
Yep.
The central sensitization that's occurred, with the OA that's lasting for years and months for, for
Yeah.
people that this is actually almost acting like a gate theory to some degree and like creating a hypoxic painful state
Absolutely.
to trigger the system to like use descending inhibition
Yeah,
for the pain.
definitely.
So what's been pretty wild is that even this is so passive, it's like having a big impact on pain and edema,
Absolutely.
which is
Yep.
we certainly hadn't seen that. We didn't realize that it was going to do that in addition to the strength of it.
Exactly. Yep. Exactly. And actually, this brings up the next section is like doing BFR in combination with neuromuscular e-stim. So there's certainly you can pair them together, and the studies have shown that. Like for example, investigators applied the neuromuscular e-stim at both 60 to 90 degrees of knee flexion without BFR, then applied BFR with the stim, and that actually increased the stimulation to 10 to 30% of muscle contraction. So just a much better quad setting occurring. And again, like if you talk about like the pain modulation and just the swelling, right? It just makes sense to combine them. And it also resulted in a 4% increase in muscle thickness and 7% increase in biodex muscle contraction. I won't read this out to you guys, but here are kind of the parameters that was recommended from that study. So if you're doing it in the clinic, this is what you'd set the frequency to that, pulse, intensity, 10 seconds on, 30 seconds off, a little bit longer recovery time. And then you would combine that with the BFR, and the goal would be to do that twice a day, which is again not necessarily like clinically possible, but at least 3 times a week or 2 times a week if they're getting it in once with you, once a day, 2 to 3 times a week. That's better than nothing, certainly.
So you would probably use like the pre-core, you think, and like set them up and do
and you could do your isometrics at 90 and 60. The stim is on, right? And then they're doing their isometrics when the machine is on, and the BFR is just off.
It's just on.
It's just on.
Okay.
Yeah. Yep. Exactly. And it also talked about upper extremity. They weren't really like it said 40%. For limb occlusion pressure, which is pretty typical for upper, and then it was like they didn't really know what the top range was for that, but they said 40% is generally where you use it. And then the intervals are a little bit different. It would be 5 to 8 minutes on, 1 to 3 minutes off, and you do 3 bouts of that. Okay, and again, generally 2 to 3 times per week for 2 weeks for that. And then another question that came up during the course is, it is safe to put the e-stim pads under the BFR cuff. So like if the cuff is like here and you want one of those up here, totally fine. Totally fine.
Oh, that's interesting.
Yeah, and then he went into, like, I probably won't go through all this either, but he just went into the importance of, like, protein intake, especially, like, for muscle sparing and muscle building, in terms of making sure the patient from a nutrition standpoint is getting enough protein in as they're rebuilding some of this muscle mass and strength, which I thought was really, really good to go over. Because that's not something I necessarily talk to patients about, but certainly, I know we're not dietitians, but even just recommending these simple things like, okay, where was it? Like, just trying to calculate how much protein would be appropriate for a patient is pretty easy based on their BMI or their weight. So, you know, for example, like someone who's 200 pounds, and say they eat 5 small meals a day, well, each of those 5 meals, they should be taking in about 40 grams of protein. And I'm guessing a lot of people are doing that. So, especially your non-athletes, right? So that was just something like that he went over. I thought that was really interesting that he covered that. Okay, so moving on to more of the endurance BFR, so aerobic BFR. So again, multiple studies. You guys can kind of look at this. We've kind of already talked about the 3 different settings we would use BFR for. But generally, the goal is to have them do it for 3 times a week. First, I think I said already, like 6 to 8 weeks. This study's showing 8 weeks is probably as long as you'll need to use it for before they'll eventually be able to just kind of transition off the BFR and just do the conditioning on their own. There are the parameters again. This is kind of redundant. Sorry. They talked about tourniquets and pain. The fact that tourniquets can cause pain, like you think about, he talked about the example of like how surgeries are performed, right? And they use the tourniquets during surgery, and patients often still have pain from the tourniquet, right? After they've been in surgery for hours, and so they talked about that a little bit. These are obviously a lot wider, so they're going to be a little bit more comfortable, but like I remember doing the lab, and you guys will feel it today, like it's not super comfortable, and that's, I think, something important to note to patients. Like, it's not going to be comfortable, it should be tolerable, but it's going to be uncomfortable probably until they get used to it. The first session is usually the hardest one, and then the patients kind of know what to expect in subsequent sessions. I don't know how much more of this we really need to read through. Yeah, and then again, it's just talking about the mechanisms again. Oh, this is probably good to talk about, is the proximal effects. So like, for example, if you're working with someone, like let's take the shoulder, for example, like they're recovering from rotator cuff surgery. So they've got a lot of atrophy back here, but we're putting the cuff distal to that. It actually, studies have shown there's a proximal effect. So even though the cuff is below the targeted muscle group, they're still going to gain strength, which I thought was kind of interesting too. So there's like the downstream fatigue, backflow proximal effect. So downstream fatigue, when individuals perform, say, the bench press at 40% 1 RM, there was significantly greater pectoralis EMG in each set among the BFR compared to the control group. So it just kind of, there's some different studies here, and then there's a study for proximal effect too. And this one goes into a little bit more details of the actual exercises that were used during the shoulder study. So they did a side lying external rotation, cable internal and external rotation, scaption. The BFR group was at 20% their 1 RM, at 50% limb occlusion. They did this twice a week for 6 weeks. The whole arm muscle size significantly increased, so it wasn't just below that increased. And then on the next page, it goes more into like the systemic effects of BFR. So again, you don't really need to read this to you guys. You can look at that yourself. The thrombophilia clinical reasoning chart is this one. I gotta get a better copy of that for you guys. He actually sent it to me, so I'll forward the slide to you guys. It's not great, even the copy that he sent me, but it was a very good slide, so I'll try to see what I can do with that. And then the blood pressure decision-making chart, that's on slide 157 in this slideshow I sent you guys, so you guys can look at that too. It shows here, again, so for blood pressure, this article by Severin in 2020, it basically takes you through the algorithm here. I wrote it out. I won't read that to you either, but I'll just go over the first one. Systolic blood pressure of less than or equal to 139. and or diastolic blood pressure of less than 89, you'd want to document in the chart and inform the patient, but it's okay to do BFR. Does that make sense? So if they're below 139 over below 89, document it in the chart, inform the patient, and then it's still safe to do BFR. And then it's like as those numbers increase, then you have to still inform the patient. You want them to relax for 5 minutes, recheck, and then if they're outside of the range, it's basically if it's higher than 180 over 110, you're not going to do BFR, and you want to inform. Also want to inform the MD. I mean, that's pretty
Exercise is contraindicated.
correct.
Right.
Right. So BFR would be too. I guess that's a good way of
Yeah.
thinking about it, right?
So you're checking blood pressure then on everybody every single time they come into the clinic?
That's a good question.
Just the
I
Mm,
probably
just
would say
the
the
first
at-risk
visit.
population I would be
Okay.
checking. I think if it's like you're young, healthy,
And you tested it
adult,
once.
at the initial.
I wouldn't worry about it. If anything in their history, if they have a history of cardiac or anything that you'd be concerned about, I mean, it's certainly good to check that, I would say, if you're even thinking about it.
Okay.
But yeah, I would say any of like our young athletes, like
Maybe check
no
it
past
once
medical
and-
history.
okay.
Yeah, absolutely. I think it's pretty safe to do it without having to check every time. There's also, in terms of promoting bone health, there's some good stuff about BFR with that. The tendons in BFR section I thought was kind of interesting too. So basically, the BFR causes an increase in lactate or lactic acid, which in turn increases growth hormones, that increases collagen synthesis, bone, tendon, extracellular matrix. There was a pilot randomized control study on the anterior knee for like patellar tendon pain back in 2018. And the study had them do long arc quads at 80% of their limb occlusion pressure and with a pain rating of 4 out of 10. So like 4 out of 10 or lower was okay. The clinical implications are that low BFR exercise may be used to reduce pain and provide a window of opportunity for clinicians to optimally load otherwise painful tissues and joints. So I thought that was really interesting because that wouldn't have been my first thought to go to like tendinopathy patients with BFR. But yeah, if they're really struggling or to do any type of exercises, even body weight. Like I'm thinking of someone trying to do like a stationary lunge and they can't even tolerate that. If their pain's above a 4, you might want to try some BFR and see if that helps modulate their pain a little bit, and it can, it's been having some positive effects in some of the studies. Or Achilles tendon, there was Achilles tendon study, patellar tendon study, and even a tennis elbow study that was showing.
This might be getting into the weeds a bit, but I can definitely see its use for pain management. I'm just wondering if with the lighter loads, if it changes how much it's actually like straining the tendon, because we kind of know it needs load.
True.
Yeah,
so that's a good
I'm
point.
just wondering,
Yeah.
like, for healing purposes, like, is there enough load with the lower weight that we're using?
That's a good
It could
point.
be more pain management, but
It
then
could be,
as the pain gets less, then you can actually truly load it.
Yep. I think that is definitely something to think about. In the Achilles tendon study, they did find that BFR caused muscular and tendinous adaptations, which are similar to high load resistance training. So it basically the same response for the patellar tendon group and causing like a bigger and stiffer tendon. So the same, it's basically showing that I think there's not as many studies about tendons. It's more about, there's a lot of studies about muscle, right? But the tendon is a little bit newer research, so I don't know that there's a lot of literature, but from what there is, they are finding that it's having similar effects on the tendons as it does with the muscles. So it is something to consider. And then it goes into talking about, I guess this is the last thing, so old muscle or elderly patients. That's what you call it, old muscle. Muscle fiber capillarization at baseline may be a critical factor for allowing muscle fiber hypertrophy to occur during prolonged resistance training in older individuals. So basically, the ability to adapt depends on capillarization in this group. So better capillarization means increase in muscle fiber hypertrophy. So that's kind of the goal of using the BFR, is to kind of get the blood circulation and increase capillarization so that they can in turn build more strength and hypertrophy over time. And then it also showed an interesting study about people with Parkinson's, who we know that group has poor vascularization in general. So it showed like a study of 65-year-old subjects. BFR was performed 3 times a week for 4 weeks at 20% of their 1 RM at 60% limb occlusion. They did bilateral knee extensions, and they did the 30, 15, 15, and then the 4 set was to fatigue. And this basically resulted in better vascularization and decrease in homocysteine levels, which is good, and it decreased the risk of even cardiac events in this patient population, which was kind of interesting. So I guess the takeaway from this group is like this patient population would benefit from like, it's almost like a 4-week vascular tune-up. Like it's for like 1 month. They come in 3 times a week or maybe twice depending on insurance, and you're just tuning them up and getting them, you know, getting that vascularization and helping them build strength. Yeah, so that's pretty much it. Sorry, I know I kind of flew through some of that, but
along the lines of the Parkinson's, I mean, most of them start with a one-sided weakness that then becomes bilateral. But I'm just even thinking about the woman I have right now.
yeah,
I assume you would put the BFR on the more affected limb.
probably. Yeah.
But when they talk about Parkinson's, they're noticing bilateral change, even when the device is on one side.
Right, correct. So even if you're doing it on the side maybe that's weaker, it will have a crossover effect on the other side. And that study, they literally just 3 times a week for 4 weeks did bilateral knee extensions and showed gains. So yeah, I mean, I guess if you had time, you can do both sides. But if your time is limited, I would probably do it on the weaker side and then know that there's some crossover effect. And you're still working both sides, right, with the exercise. So yeah, it is very interesting. Yeah. All right, lab. This is like the fun stuff. Yeah. Okay. So who wants to go?